If folks could grab a seat, get some quick coffee and grab a seat, we'll get started in 1 minute. Why, thank you. It's good to see everyone on this wonderful spring day. My name is Michael Doonan. I'm the Executive Director of the Massachusetts Health Policy Forum. Critical forum today. Cutting edge issues, right? A lot's going on in Washington. Cuts in some programs that we really need that serve the most vulnerable. And it is all about the most vulnerable. And that's what our forum is about today. I stand here with a heavy heart because we lost the chair of our board, Phil Johnston. Huge, deep loss. But we want to dedicate this forum and all of our forums to Phil Johnston going forward. And I'll make a special announcement about that in a few minutes. I want to thank our sponsors, the Massachusetts Blue Cross Blue Shield of Massachusetts, Bay State, Bowman Family, Goodness Web, and of course the Massachusetts Association for Mental Health. Thank you so much for all your work. Ben, Concert, all of our sponsors. We really appreciate this. Couldn't go off without you. The Massachusetts Health Policy Forum board members, thank you so much for your service, and we have a number of you here today. Michael Curry, thank you for your help for us. Thanks for your help today as well. Secretary Mahatmya, Dr. Mahatmya, are you here yet? He'll be here in a bit. Thank you so much. Audrey Shelto, we really appreciate your help and support. Chris Hager, I know I saw you over there. Thanks, Chris. Good to see you. Thanks for your leadership. John McDonough as well. John, thanks for all your leadership over all these years. Connie Horgan is with us today. Connie, Ian Lang, thank you, Ian, and Barbara Rapson. It's just wonderful to see you. Senator Sear will be here if he's not in a little bit. Representative Sangiolo is here as well. Thank you. Great. All right, we're going to start with a tribute to Phil Johnston. And then we're going to have a presentation of the research, and then we're going to have a break, and then we're going to have a panel discussion. Okay. So, Phil, what can we say? Irreplaceable. Just an incredible human being. So we want to dedicate this forum, and I have a special announcement to make that the new name of the forum will be the Philip W. Johnston, Massachusetts Health Policy Forum. You can apply for that, absolutely. And we're so pleased, and we're able to do this. This was the idea of Bill Van Fossen, who was the former CEO and president of Blue Cross Blue Shield. He helped organize the forum with Phil on a walk in the city. They said, you know what? We need to have a forum that convenes stakeholders around the latest research to have an impact, to have more discussion, to have more talk. And that's the secret sauce of Massachusetts, right? People who are in health policy know each other. That's why we were able to get reform that became the model for the nation. That's why we're able to work on things like primary care reform and other things that are happening. That makes Massachusetts a leader. Phil Johnston was instrumental in all of this. We really want to thank the Blue Cross Blue Shield of Massachusetts Foundation. I had a call with Sarah Islin, who supported this and is putting funding in for this, and we really appreciate her and their support. Phil Johnston, irreplaceable, just irreplaceable. Now, every time I met with Phil Johnston, we laughed. Every time. Is there any other person in your life where that happens with? No, that is rare, and that is super special. So when we had these meetings, they took a similar format. So Phil would check in with family and friends. He'd ask me about my children, ask me about connections. He was such a connector, but had such a huge heart. And then he would talk about something in the Boston Globe that he hated. Oh, I can't say they said that in the Globe. Or something that he loved in the Globe, right? And then he would say something irreverent, probably about Republican policy. And then he would praise FDR, and then he would praise the Kennedys, right? And then we would get, and I know some of you relate. You've had similar meetings with Phil, right? And then we would get down to business, the business of the Commonwealth, the business of helping folks, because helping folks is what Phil did. In his heart, he was a social worker, and he was a social worker to the core. He always pushed for mental health and behavioral health services, Donna. He really respected and admired you. You were on speed dial, and he called you with problems. Now, if Phil came to you and said, hey, can you help me with something, what did you say? Yes. You said yes, and you said it right away. And Phil was there to help you, and he was there to help us all. If you had someone who needed a problem, Phil was right on that. And he helped you, and he helped many of us as a mentor with our careers in many ways, and for that we'll be forever grateful to Phil. Yeah, just a huge heart. I mean, one story comes to my mind. This was 30 years ago. Well, it was 23 years ago. My daughter was 7. Right, and she played the violin, Samantha, and Phil knew this, and he said, you know what, I'm going to invite you all to the Boston Pops for Christmas. And so, and this was the time I was a PhD student. We didn't have a lot of going out money, and my daughter got a red velvet dress, and Phil just chaperoned us to the Pops, and it was just so wonderful. Now, I just mentioned this story because that touched my heart, right? But for Phil, he did that to thousands of people. Right? He was just so generous and just so kind. He can't be defined by his resume, but we should pay attention to it because he made some significant contributions. He was a 3-term state legislature, and there is nothing more important than public service, right? And we need to hold that right now more than ever, because we shouldn't take it for granted. We shouldn't take democracy for granted. We can't, and Phil never did. He was on the front battle lines for democracy. He was on the front battle lines for equity. He was on the front battle lines to make sure that everyone had an opportunity to vote and to get engaged in the system. You know, Phil was on a bunch of different boards, right? A ton of them. But one of the most important was the Blue Cross Blue Shield of Massachusetts Foundation Board, because they did cutting edge work. To make healthcare reform happen, to get Massachusetts close to universal coverage, to be a model for the rest of the nation. You know, in the Navy, and I had an old student of mine who was an admiral in the Navy. He says, you know what? It's the first captain that sets the culture for the ship. And I think that Phil set the culture for that foundation. He set the culture for the Massachusetts Health Policy Forum. Right, and those organizations will live on in his name, and we will specifically and literally and directly live on in his name because we are using and carrying that name forward. Phil was also engaged nationally. Michael, he cared so much about community health centers. It was prime and center and focused of his career, throughout his career. Why? Because they serve the most vulnerable. Why? Because they serve diverse populations that have been neglected historically. He cared deeply about that, and we need to continue that work in his name. Yet Phil was also regional HHS director for New England, just like Chris preceded him. Really, so his reach was far beyond Massachusetts. All right, so we dedicate this forum, we dedicate our work to Phil. I just want to end this part of my remarks and dedication by quoting a colleague of mine, Anita Hill. She said that some people say justice it's not a sprint, it's a marathon. Well, she says it's not a marathon, it's a relay race, and a relay race that gets passed from one generation on to the next. And Phil passed that torch far too early, but he did pass that torch, and he passed that torch to us. And we need to rededicate ourselves. Many of you do this work, right? And we need to do it. We need to do it better. We all do in Phil's name. Phil would not want a moment of silence. Phil was not a quiet man. But if you are able, please stand and applaud as loud as you can to get it to heaven for Phil Johnston. Oh, you know what? I missed one important, huge, massive thing in his life as Secretary of Health and Human Services. He was the second longest ranking member, secretary. Now, who was the first? Mary Lou, it's good to see you here. Yeah. I think I also saw Lauren Peters from CHIA here too. Thank you for being here as well, Lauren. Great. All right, Donna, it was just been a pleasure to work with you on this forum. And as I was saying, really critical. Mental health, behavioral health issues critical on Phil's agenda. He helped organize this forum, too. He said, we've got to work with Donna. And when Phil says you got to work with someone, you got to work with someone. But it's not because of that. It's just been a real pleasure. So you are the president and chief executive officer of the Massachusetts Association for Mental Health. You worked at APT. You have a huge background in advocacy, in justice, and in research using data that matters and impacts people's lives. But I think, the most important thing about you is you have your PhD from the Heller School. Please welcome Donna.
Good morning, everybody. And Mike, thanks so much for your generous comments. I was privileged to, you might need these? Oh, I might. I was privileged to get my PhD at Brandeis. The dual disciplines of social policy and healthcare economics have really stood the test of time and supported my work. So thank you to the Brandeis crowd here today. Many thanks to the Massachusetts Health Policy Forum. It's really a privilege to be here. I appreciate so much the large and diverse community of people here today from Massachusetts, a community that always comes together in the interest of people in need and finds a way to parse through differences to get to constructive solutions that in the end make a difference in the lives of so many. I'm grateful to all of you. And we have friends here today from New York and Texas and North Carolina. So thank you very much for joining us. To the practitioners and policymakers and payers and reformers in the room, and to the folks from the philanthropic community, thank you for coming together today to listen and learn and talk about collaborative care as a solution to meeting the needs of people who have complex health conditions. The MAMH board and staff, thank you so much. That incredible team that greeted you on your way in the door this morning, along with Ashley, I really appreciate you being here. Legislators, Rep. Lenatra, Senator Sear, others, thank you for being here. Our policymakers, practice leaders, one of our sponsors who's here today from Bay State, Barry Sarvet, thanks so much for being here. And Massachusetts Blue Cross Blue Shield, thank you so much. The Bowman Family Foundation and the Goodness Web have been supporting this work to examine the utility of collaborative care as a model of integrating behavioral health and primary care, and are underwriting this effort today. Thank you very much. And Matt Bowman is here today, and Dr. Celine Coggins is here today. Thank you so much. Audrey Shelto, I want to thank you because Blue Cross has been a big supporter, and Greg Harris is here. You'll be meeting him later, of the efforts of this Mass Health Policy Forum, and worked so closely with Phil, who we are so grateful to for his inspiration. So MAMH, why are we here? Why are we talking about this? We were founded back in 1913 by a person in recovery, and he described himself that way long before it was a fashionable term in the behavioral health field, who was the leading mental health advocate of the day, a highly regarded Boston business leader, and the then president of a major university across the river. Our mission has been to advance mental health and well-being and promote prevention and early intervention, effective treatment, and research to address social, emotional, and mental health challenges. More importantly, we have been dedicated to eliminating stigma and the pernicious discrimination that grows from stigma. We want to ensure full social, economic, and political inclusion for people in all aspects of community life. The issue brief really addresses the escalating crisis in the availability of timely, affordable, and effective treatment for mental health and substance use disorders. Evidence suggests that the implementation of the collaborative care model can alleviate years of needless suffering, and that's really why we care about this. This is about people, vulnerable people, as was mentioned earlier, worthy people, people who should animate our policy debates and inspire our action. And I thank you all today for keeping them in mind as we discuss this. It's been a privilege to expand our earlier work at the association to secure coverage for collaborative care and to dig deeper into the compelling evidence, examine the successes here and elsewhere, and understand the challenges of adoption, practice, transformation, and sustainability. I want to thank Phil Johnston for his inspiration. He was an indefatigable advocate, and he could relentlessly, and he did relentlessly, enlist all of us in worthy causes, challenging causes, with an optimistic worldview. And he was always focused on the worth and dignity of the human beings on behalf of whom he acted. I want to say to Mike Doonan, here you are, and Ashley Osorio, thank you for working together to make this happen. Connie Horgan from Brandeis and the Schneider Institute. Our funders, as I said earlier, we can't thank you enough. The issue brief co-author, Michael Uhas, not able to be with us today, from the Bowman Family Foundation and the Mental Health Treatment and Research Institute. And my colleagues, Louise Paval and Marty Cohen, Dr. Melanie Wasserman, Dr. Jonas Bromberg, and Dr. Trina Chang, who worked together on the background work here. Michael Curry, thank you for being here today. This is a man who leads the Health Equity Compact. He leads the NAACP, the Mass League for Community Health Centers, and so much more. I bow to you. I thank you so much for coming to work with us on this today. Wayne Altman, you'll be meeting later, the enthusiastic advocate for primary care reform in the Commonwealth, and manages to juggle an active family practice, which is why he's speaking early today, because he has patients to see, as well as being department chair at Tufts and founder of MapCap, and in his partnership with the Brookline Center has been practicing collaborative care. I'm looking forward to hearing about it. Verna Little, our speaker this morning, she is fresh from being awarded the Lifetime Achievement honor from the National Council. The last time she gave a speech a week ago getting that honor, she was speaking to 6,000 people, so I'm pretty confident she can handle a crowd of this size. Undersecretary Mahania, if he is here, he is a practicing family physician, as he really leads with, and it informs his policymaking at the Executive Office of Health and Human Services. We know what a challenging time it is to take responsibility for the state's mass health program, and we appreciate you being here today. And the Mass Medical Society recognized him for his compassion and dedication to the medical needs of his patients and the general public. And we are grateful that you have stepped into government to work in that role now. Dr. Patrick Aquino is going to be on the panel today, has spent 10 years refining the practice of collaborative care at Tufts. Trina Chang, who I mentioned before, from Mass General Brigham, a similar career working on integration and soon to go to Tufts. Greg Harris, Chief Medical Officer for Behavioral Health at Blue Cross. This is a man who actually enjoys codes and, and was chair of the American Psychiatric Association's Committee on, I'm going to read this so I don't mess it up, Resource-Based Relative Value Scale Coding and Reimbursement. Thank you very much. All right. The next main event, Senator Sear, Senator Julian Sear is joining us. He is the Assistant Majority Whip, the chair of the Joint Committee on Housing, vice chair of the Joint Committee on Public Health, which he used to chair, and also used to chair the Behavioral Health, Mental Health Substance Use and Recovery Committee, very well informed on the issues. His oversight of healthcare financing, mental health substance use, and also racial equity and civil rights, inclusion. The list of his concerns and accomplishments is long. All right, so he is a major author of and a major reason why we have Chapter 177 of the Acts of 2022, which was an act to address barriers to care for mental health, the ABC Act in short. It stands today as the most comprehensive reform to mental health care and behavioral health care in the Commonwealth in decades. The roadmap for behavioral health reform was embedded in that legislation. Secretary Sutter's the author of that. A couple $100 million in behavioral health workforce investments, and that was really just the beginning. The Office of Behavioral Health Promotion and Prevention was created there, and to our point today, an annual mental wellness exam for everyone in the Commonwealth, and collaborative care codes activated across all payers. He also led the 2024 Maternal Health Omnibus Bill, and that has coverage for postpartum depression screening, universal postpartum home visiting, and perinatal mental health. He has long been an advocate for suicide prevention, an important outcome of collaborative care, and a post-vention task force that he created at the Department of Public Health. He is now the Senate lead on any number of issues, but one of those is collaborative care. He filed legislation along with Rep. Lenatra. It is Senate 1390 and House 2220. It's an act relative to access to psychiatric collaborative care. Finally, I will say he is deeply committed throughout his career to health promotion and illness prevention, getting upstream in the process, and in his own words, he is relentlessly focused on expanding access to health care. Please welcome Senator Sear.
Thank you, Donna, for that very generous introduction. And it's so good to be with, I see so many friends in the room, which is really cool. Apologies if I'm a little blurry. I was in Cindy Friedman's office till a little past 11 p.m., not a.m. Oh, God. A little past 11 p.m. with Joe Comerford and Robin Kennedy, so you can imagine we're cooking up some good trouble, right? But and really, I want to thank Donna for her friendship and guidance. I'm someone who's spent most of my career working in public health, but when the Senate President asked me to take the mantle of chairing the Joint Committee on Mental Health, Substance Use, and Recovery, and then helping to really lead and shepherd the Mental Health ABC Act, which is her number one sort of personal priority, navigating and understanding behavioral health, which is dauntingly complicated. I think it's just been designed and purposely designed to be complicated in many ways. And Donna was the best Sherpa guide you could have in navigating that and figuring out. And so whether it's on really complicated policy or just in figuring out how people get access to care, who do you call for advice, Donna, you're invaluable, and I really am grateful for your friendship. I know the Blue Cross Blue Shield Foundation was also mentioned this morning. I don't know if I'd actually be here. Part of how I got the idea, which was a very wild idea at the time when I first ran for office in 2016. I was a 29-year-old queer kid from the smallest town on Cape Cod. My family's not political. Like, I'm not supposed to have this job, right? But a few years earlier, I had participated in the Blue Cross Blue Shield Foundation's Community Health Leadership Program. which takes public health leaders. It's almost all women, of course, and I was one of the two boys in the program. But I think in that program, it was in like 2013, 2014, was when I first sort of got in my head. I was like, hey, wait a minute, like, I work with these legislators all the time. Like, this isn't rocket science. Maybe I should do this. So I do owe a real great gratitude to Audrey and Michael and so many people involved in that organization. And of course, Phil Johnston, who was an early friend and mentor to me, and we're just really grateful for really his example, right, and what public service can and should be in this Commonwealth, and what an incredible legacy. And also exciting to be here, albeit a little early, to talk about collaborative care, right, especially in a room full of people who are not just talking about making things happen, but are making them happen. Which is one of the most valuable kind of people you can talk to as a legislator, right? Lots of people have opinions and thoughts, but when you actually talk to people who are on the ground trying to work, trying to punch in those codes to make collaborative care work, it really helps you refine your policy. I think as you'll hear again and again today, collaborative care is this evidence-based model, right, where we're integrating behavioral health and primary care, and it just works, right? It's proven to improve access to timely and effective care. We know it reduces suicide risk, it improves health outcomes, it advances health equity. It also lowers overall healthcare cost, right? In short, it basically checks every box of what we're trying to do here in Massachusetts. And from my time at the Department of Public Health, right, back when I was a mid-level bureaucrat, I didn't get anywhere near the Secretary's office under two administrations. A little bit, Mary Lou, a little bit, but really it was when I caused trouble when I got to the Senate. But actually, I caused more trouble in the Patrick administration than Baker administration, I think. I think public health brings a remarkable lens, I think, to this work, and I'm really grateful for some of the folks I worked with and who mentored me, and got to see their examples at that agency. But really seeing how housing, access to work, prevention, right? These aren't sort of separate, siloed issues. They're interconnected, and they're shaping our health outcomes each and every day. And I think when we pretend that they're not, we get ourselves into a host of trouble. We've heard the Public Health Committee earlier this year held hearings with providers, and we just hear this message loud and clear year over year, right? That we're in a crisis of timely access. We continue to see workforce shortages, both in behavioral health and primary care. One of the things I was really proud to be involved in when we had quite a bit of resources, unlike today, but go back a few years ago with ARPA, we had very significant resources to the state, and was very proud that the legislature, but especially the Senate, led the way in allocating for $400 million to behavioral health, $192 million of those dollars to a behavioral health workforce dedicated account, a trust, and then we work to figure out how do we direct dollars to our workforce to retain and bolster our workforce with loan repayment, with scholarships, paying for clinical supervision, paying for internships, great partnership with the Baker administration, great partnership now with the Healy administration in rolling that out. So just a real example of what I think we're trying to do, what we've tried to do on our workforce. But I think we know that prevention and early intervention has to be front and center, and it starts in primary care settings. Right? And you all know this, right? Primary care, this is where people show up first, and it's where I think we can recognize signs of behavioral health issues first. And so this is where that intervention can have the biggest impact, and yet we haven't enabled our primary care providers to be able to do that work because they don't get paid for it. I think as Donna gave you an overview of Chapter 177, the Mental Health ABC Act, which I was so proud to have been one of the co-authors of, but these requirements, right, where we really tried to integrate collaborative care, or begin to integrate collaborative care into that law. The annual mental health wellness exams, having that covered with no patient cost sharing, requiring payers to cover collaborative care codes, so providers can act, right, when a need's identified, establishing suicide postvention as a real concept, creating a behavioral health promotion office, right, to really coordinate all the sort of disparate sort of behavioral health work that was happening over several agencies across a secretariat. So we're very proud of that work, right, but we know that it's not enough. So we're trying to keep this up. And this session was delighted to partner with Representative Lenatra, who I know you're going to hear from later today, who's joined us today, on an act related to access to psychiatric collaborative care. That's House Bill 2220 and Senate Bill 1390. So the bill would raise collaborative care reimbursement rates to 100% of Medicare, and this would ensure that providers are adequately compensated for delivering integrated care. Really, the aim here is to boost adoption and, again, improve mental health services. And the bill would also allow billing outside of primary care subcapitations, right, again, to make collaborative care financially viable for practices. It's not enough just to have the codes. We need to make sure the codes work, they're able to access it, and it's put into effect. And then certainly, of course, the work that was mentioned, and I was just glad to be sort of a behind-the-scenes partner in the maternal health work that was led by many champions, including my friend in the House, Marjorie Decker, Senator Liz Miranda, Senator Friedman, Senator Roush, many others. But again, embedding in coverage for postpartum depression screenings, which is something we had hoped to do in the Mental Health ABC Act. It fell out in negotiations. We came back, we got it done, expanding universal postpartum home visiting services, and creating a perinatal mental health grant program. Again, recognizing that mental health checks have to be every step of the process, every step of the care. So this work is not over, and even this week, we continue to push ahead on mental health, on integrated health care. Senate budget has very significant levels of funding for behavioral health and mental health in a very tough fiscal environment. But two sort of late-breaking wins that we're able to get just this week. I filed an amendment working with our partners in the Children's Mental Health Coalition to establish a statewide group to really continue this work around overhauling access to care for children and families, identifying barriers to access, and creating concrete next steps for the state to take. So this group's going to take a look at the feasibility of creating a single integrated agency dedicated solely to children's behavioral health, and just really just trying to keep that kind of conversation and keep that work going. There's always sort of this tug and pull. I see the secretary shaking her head. Well, no, what's happened, right, under Secretary Sutter's leadership, we really had behavioral health and mental health was really at the secretariat level, right? This Office of Behavioral Health Promotion was designed to sit at the secretariat level, right? Because you have a Department of Mental Health that's doing some work, a Department of Public Health that's doing another chunk of work, other sort of issues, right? This has been a little bit pushed down, I think, into the agencies, and I think how you figure out this really fragmented coordination among I think one agency you have very much focused on folks who have really significant acute mental illness. You certainly have the Department of Public Health, which is, I refer to lovingly as a true believer agency that's, ready to roll up their sleeves and kind of anything. And I think we're wanting to kind of keep that approach. I think we'd like to see that approach where you have some level of integration and coordination across these agencies and it's not siloed, because our patients who are receiving care, their lived experiences aren't siloed. So part of that work is to sort of keep things in the secretariat. Also, we've really prioritized youth at risk funding as well. We added some significant dollars to this. This is a line item where traditionally we do a lot of earmarking in that line item, and we erode the evidence-based funding. So another piece we were able to add to that in the debate was boosting the funding for the evidence-based program. So those are just sort of two pieces that we worked on. There's a number of other provisions that are in this budget that should do a heck of a lot of good. Certainly tremendous amount of uncertainty in this environment. I think the actions, early this morning, by a Congress that is pursuing a reconciliation package to give away tax breaks and gut our Medicaid program is truly abhorrent. And I think as we actually see what emerges from this, right, it's a bit of a wait and see approach, but certainly this is going to add a new layer of challenge for us. This is a deeply challenging time, but also I think there's some opportunity. in that challenge. We have urgent need. Our system continues to be stretched. But we do know it works, and I think we just have to keep on pushing that across our sectors to make sure that we're advancing collaborative care. This just makes sense in the way that we should be doing things. Our lived experience, our bodies, aren't sort of severed from, our brain to everything else, right? And so how we undo, I think, the harm and the really sort of flawed thinking from decades and even centuries ago about approaching healthcare is part of our aim today. So you're going to have a fabulous, wonderful rest of, when does this go to? Day, afternoon? You'll have lunch or something. I've got to go back up the hill. We have our last day of debate, hoping to make some important progress for community health centers and a few other issues that are outstanding. Also, we got to resolve, I think 117 Bruce Tarr amendments or something. But I am really grateful now to introduce to you Dr. Wayne Altman, who has been putting this model into practice and can speak far more eloquently than I around what this really looks like on the ground. Dr. Altman chairs the family medicine at Tufts University School of Medicine. He's the president of the Family Practice Group in Arlington, and he's leading collaborative care implementation through a grant from the Accelerate the Future Foundation. So please join me in a warm welcome for Dr. Altman.
Thank you so much, Senator Cyr. I have to push back on your remarks a little bit. One thing that you said, that you weren't meant to be in this job. You are clearly meant to be in this job. And your leadership with mental health and collaborative care and community health centers is so important and so appreciated. So thank you very much. Thank you so much, Donna, for inviting me to be here. And I'm just going to grab this. I've got something.
Take my name tag now.
I am not Michael Doonan. Here you go, Michael.
Oh, no,
So, Senator Cyr referenced it. Obviously, I think we all know we're living through some really unprecedented and deeply troubling times. And I have to say, one elixir to that is to be in a room full of people like today, where each and every one of us wakes up in the morning thinking about how we can make the world a better place for those around us and serving others. And it really is energizing and healing to be around people like you all in this time. And we really need to think about how we can have courage and fight the unnecessary harms that are being inflicted on others at this time. So I, about 6.5 years ago, started an organization called MAPCAP, Massachusetts Primary Care Alliance for Patients. And we've been working on primary care legislation in Massachusetts for the last 6.5 years. And when we started, I was told this kind of thing takes about 10 years. And for those of you who know me, I don't have a lot of patience. And I am feeling really confident that at the end of this session in July of 2026, that we will pass major historic primary care legislation in Massachusetts that will become a national model. And we'll be 3 years ahead of schedule, so that's good news. And so I think all of you know that we have a crisis in primary care. If any of you do not have a primary care physician or clinician right now, I wish you the best of luck in finding one. It's a really difficult thing to do. And even if you do have a primary care clinician, go try and get an appointment with one in a timely fashion and see how that goes for you. It's not acceptable. Primary care has a triple superpower. We improve health of a population. We decrease health disparities. The National Academies of Sciences, Engineering, and Medicine in their 2021 primary care report said that primary care is the only aspect of medicine that both improves health and decreases health disparities at the same time. And the triple superpower is we do both of those things, all while decreasing the overall cost of healthcare, more for less. And yet, in our infinite wisdom, in Massachusetts and in the country, we spend 6 cents on every dollar, only 6 cents on every dollar for primary care, while our peer nations, who have dramatically better outcomes than we do from a health point of view, spend 15% of their healthcare budget on primary care. So we're going to fix that. And we have actually 3 primary care bills before the state legislature right now that is going to double primary care investment. It is going to be a jolt of energy towards health equity in the Commonwealth of Massachusetts. And it's going to make a real difference in access to primary care and the quality of care and the health of the people of Massachusetts. And so we're really excited about that. And when you practice primary care, when you see patients, you realize that every day, every patient, that medical care and mental health care and people's mental health and physical health, they're not isolatable. They're all intertwined. And so behavioral health and mental health is married to primary care. It's just that we're not living together yet. And we really would like to be living together. Occasionally we are. In my office in Arlington, we've had integrated behavioral health for about a decade, and then we discovered collaborative care, which is kind of they're not the same, but there's a lot of overlap, and it's kind of a more advanced, more effective version of integrated behavioral health. And I've gotten, over the last 2 years, I've gotten the opportunity to watch the pure magic that happens when you have mental health clinicians embedded within a primary care office. And, you know, to be able to say to a patient who's struggling with their mental health that we can help you with that. How about if I introduce you to the person who's going to help you with that? And how about if they give you a call later this week to set that up? And after you watch their head spin, because they weren't anticipating having access to mental health care so quickly and so affordably, and then you see them 2, 3, 4 months later, and you say, well, how'd that go? And they say, yeah, I feel much better now. It went great. Thank you. All the things I needed access to, they helped me get access to. And we have a care manager in our office who's like the quarterback of the whole operation, who does incredible work. We have a mental health clinician, a therapist who's here today with us, who does incredible work with our patients. And we have a psychiatrist that we meet with once a week over Zoom. And we get to ask questions of this psychiatrist about how to handle the pharmacotherapy for our patients. We're pretty good at it. You know, we've got game. But sometimes where we need a little bit of help, and the psychiatrist is fantastic. And when we first met him, we said, listen, we're family doctors. We don't like to over-prescribe and over-treat. We like to be gentle with our patients. And he said, it's okay. I'm with you. It'll be fine. And he was telling us the truth. So it's gone really well. And I know we're a little bit behind schedule, so I'm going to stop here and just thank you all for being here this morning, and thrilled to be in the fight with you all to increase primary care access and mental health care access in Massachusetts, in the United States, and to help us live together.
Great. Well, thank you very much. And critical, important work. Thank you. Let's bring up the researcher. And Michael, can you join us? All right, so Michael, you've been introduced, but the one thing that they forgot to say was that you're on the Marjorie and show on WBUR. Enjoy that every time you're on. Welcome. Thanks so much for helping us.
Thank you, Mike. Yeah, thank you. So good morning. I need a little bit more call and response. Good morning. I'm going to start at least my participation in today with a confession. And I'm embarrassed to say this. I did turn my heat on last night, and I did dig out my winter coat. I will say that because I was talking to a few folks as I walked in, realizing that this weather is not what we expect in the spring. So I want to start. One, let's give all yourselves a round of applause for being here in a nor'easter when it's cold out. I think many people have heard me say this, that I think my mother, because she was born in Alabama, I feel like I have Alabama blood in me, so I was meant to not be in Boston. And I complain about the weather all the time, and I always say I'm going to move to some other warmer place, particularly in the South. But then I'm reminded of the politics of those other places. So I want to give credit that I'm thankful we live in Massachusetts, particularly with the Massachusetts Health Policy Forum, with a Health Policy Commission, with the Massachusetts Association of Mental Health, with phenomenal leaders like Michael and Donna, Secretary Sutters, Christy. I mean, we are very fortunate in Massachusetts. So if I can tee off this conversation with anything, is as we pay attention to what's happening across the country, federally and in states, we are very fortunate to live in Massachusetts, where we can have this conversation. I want to quickly mention my connection to Phil Johnston. I've known Phil for over 25 years. I actually used to work for Bill Van Fossen and Peter Mead for 16 of my years at Blue Cross, and I got to spend a lot of time in the lobby of Blue Cross Blue Shield connecting with Phil over the years. So even before our connection for community health centers, we had created a bond. He had texted me really just days before he passed, and he said, "Thanks for doing this event, Michael. I know you'll be great." And that's special for me. So right now I'm meant to be in Aruba, and I'm here on Memorial Day weekend. But I'm thankful to be here on behalf of Phil, who was constant encouragement for me. And we are the recipients of funds in his name. So I've talked to Beverly and Robert quite a bit in the last 2 weeks by text and by phone. And we're planning to do a fellowship in his name as well. So I'll keep you all informed on that. Last but not least, if I look a little sluggish, if you see bags under my eyes, some of you far away won't see that. It's because I was up at 3:30 this morning, Joe Feaster, texting back and forth with Ayanna Presley, who was voting. So I think she texted me thinking I'd be asleep, and then I responded, and we had an hour text conversation while she was on the floor voting. And, of course, that House tax and spending cuts bill passed by one vote. And she reminded me in the text the phenomenal leader we have in Jim McGovern, who just lost his daughter Molly just a month ago and has been on the floor and fighting there in D.C. So when you see Congressman McGovern, let's all express our gratitude. So today you have in front of you cards, housekeeping. Please write your questions down. Questions are required. I'm making that up. It's not required. But please write down questions. We want your questions today as well. So I'm going to do this quickly, is introduce our researcher for the presentation and then get out of the way. We'll come back with the panel. Dr. Werner Little is currently the co-founder of the Concert Health, a behavioral health medical group providing collaborative care to healthcare providers across 19 states. Dr. Little is also the co-founder of Zero Overdose, a not-for-profit addressing the national crisis of unintentional overdoses. Dr. Little served as a special advisor to the New York City Mental Health Commissioner, directing the Center for Innovation in Mental Health, housed at the New York City School of Public Health, senior vice president for a large FQHC. She served for 22 years in New York City, overseeing over 300 hospitals as a citywide family violence coordinator. She has a doctoral degree in psychology and a master's in social work. Dr. Little is a nationally and internationally known speaker on collaborative care. She has consulted in all 50 states to help build collaborative care services and routinely works with states and large systems on collaborative care implementations. Can we give Dr. Little a round of applause?
Okay, well, that was a lot. So super glad to be here. I know we're running a little late, and I've been given the task to catch us up just a tiny bit, so I'm going to try to do that, which is probably worrisome for some of you who know me, who are like, she could talk about collaborative care all day. So I promise you, I will not do that. But what I will do is 30 years ago, almost now, in actually 2001, so not quite, 25 years, when I did the first implementation of collaborative care after the research trial ended, I drank the Kool-Aid. And my goal here today is for all of you to leave having drank the collaborative care Kool-Aid. And so whatever questions you have, whatever reasons you have that it hasn't worked, you don't think it can work, bring them and let's talk about them and let's do our best to really move collaborative care forward. Because these are the people that in this room that are going to be able to really make that happen. So super glad to be here and super glad to talk about some of the things that we found. So I feel like I'm preaching to the converted a little bit, just knowing what the rising needs are. I can tell you that we are seeing increased acuity. Some of that is access, some of that are things going on in our world, right? How I originally got involved in some of the suicide work was I was sitting in my office in the FQHC going, wait a minute, something's going on. I'm having more people die by suicide. You know, things are not, and I realized, wait a minute, we're not doing a good job. And so started to figure out some of those processes. So we all know that there continues to be a need, particularly in pediatric practices this morning. I did some coaching calls this morning with pediatric practices. They're struggling. They're really struggling to figure out how to meet the behavioral health needs of their patients. And there's no access in their community. So we're really trying to do that. We also know that many people just don't get care. We work with a lot of practices in Missouri and Oklahoma, and even, you know, my experience working with practices in New York, there just isn't anyone in the community. I work in Montana. They had a suicide homicide last week, and there's no services in the community. We're like, we want to connect people in the community who need support, and there were really very few options. And so really wanting to make sure that we can change that. We also know, and I know this from working in an emergency room for 17 years, we see a lot of people in the emergency room, like these are the folks that are really driving up some of the costs. And these are fixable, right? Like a lot of those people don't need to be there. We can change this script. So really wanting to be able to do that. So all of you know some of the Massachusetts data, so here it is. We're going to share the slides. I want to try to take you to some of the important stuff, talking about collaborative care. So one of the things that we know is particularly now for some of the specialty care that we can do effective collaborative care and partner with them. And so we want to make sure that we're actually working with all providers across the spectrum, pediatric, cardiac, GI, you know, some of your geriatric providers, primary care providers, women's health. We have been successful implementing collaborative care across the board. So I really like to just ground us all in what collaborative care is, because it has changed. I'm actually now working on a paper that talks about the effectiveness of collaborative care in individuals more on the severe, you know, scoring 20 and up sort of spectrum. But collaborative care is an evidence-based model to identify and treat individuals with behavioral health conditions in healthcare settings. End of story. That's really what it is. And I think that now the research is overwhelming. It's something like 110 RCTs now, not to mention all of the research that's not randomized controlled trials like that is out there. My buddy Claire and I from Meadow swap articles like almost every other day, right? Oh, look what I found, here it is. That articles are coming out all the time on implementation and effectiveness. So really, it's just continuing to grow. Dr. Altman talked about what the model is. There's a lot of discussion about that behavioral health care manager role. One of the problems is that the states have sort of taken it to their own to put in different guidance around who should be the care manager. And I think that's created a lot of confusion sort of nationally. But we do know what works. We do know what effective people look like in this role. We do understand what a good registry looks like. We do understand what EMRs have the functionality to have a good registry or not. We do understand now, and there's a growing body of individuals who actually do psychiatric consultation and collaborative care, for their primary gig, right? And so we have a growing group of people who really understand collaborative care and can be in this role. So we know that we're seeing good outcomes. We know that having individuals in that behavioral health care manager role, generally a caseload of 90 for adults, 75 for kids, helps us expand access. We know that they can be remote. And a lot of people still ask me about that remote. And they say, well, you like remote because concert is remote. And actually, when I did the first implementation of collaborative care, however many years ago, they were remote because collaborative care works by the phone best. If I talk to you and we set a goal and I follow up with you the next day or the day following, that just works better by phone. That's just how collaborative care is by nature. And so always sort of taking that up and talking about it a little bit. So that monthly case rate is really a gift. Generally, what we see sort of nationally is about 4 to 6 months is sort of the average. I do a lot of work in New York, and I think we have 9 patients that are in collaborative care in the state that are over a year. Most of the time, we really sort of talk to practices about how to monitor outcomes and what that sort of looks like. But essentially, that's sort of what you see. And we're starting to see some of what the costs look like. And I think this is really important information because what I do with a practice right from minute one is a pro forma. And we have a really good pro forma now that I actually do live on the phone with practices. Here's what your reimbursements are. Here's what your caseload is going to be. Here's what your costs are. And this is what it's going to look like for you month 1, month 2, month 3. And we can sort of build it out. And that does a couple of things for them. First of all, it says, okay, I really understand the finances. Second of all, they know at what point they're going to be self-sustaining. And I think that's really information that helps drive an implementation. So this sort of cost information is really helpful. What we do know is that if we're not at least 100% of Medicare, you're kind of in trouble. Because the rates just aren't high enough to really be able to support what you need to do to really do collaborative care sort of into fidelity. And actually, states or places where they've gone higher, like North Carolina or some of the other payers, that's where you really start to see more adoption. Unfortunately, they sort of didn't do it across the board. But if we were going to really have a launching point, we would say 140, 150% of Medicare would really do us solid. And boy, collaborative care would rock it. So those are sort of some of the conversations. So these are some of the tools that we're using, and I think this was important to put in. Pediatric collaborative care is growing. We convened a group with people from around the country, and we did a pediatric pathway for ages 6 to 11 because we really wanted to give people information in one place and a roadmap for them to start to be able to do collaborative care in that population. We now use a lot more tools in collaborative care. So the PHQ-9 and the GAD have been sort of standard for depression and anxiety, but actually using the PCL for trauma now. We're doing a project with bipolar where we're doing the patient mania questionnaire and the PHQ and engaging patients with bipolar. The PSC-17, the pediatric symptom checklist, you can use it to screen, to monitor symptoms, and there's some outcomes. So it really now, there's a good body of evidence and a good solid support for expanding the populations that you can engage in collaborative care, track symptoms, and monitor outcomes. So glad to share more of this if people are interested. One of the things that we know is that certainly the psychiatric consultation helps expand access, right? That you have a psychiatrist who can now really touch many more people. And one of the reasons that I really have always loved collaborative care is because I can get that psychiatric consultation, sometimes same day, but definitely within a week because of that weekly meeting with the psychiatric consultant. And so that's incredible. And we've really learned about how to help practices prioritize who they bring to psychiatric consultation. We just did a video really role modeling that we have sharing out with the world so that people have a good foundation to really make this optimal. There's still some confusion around some of the CMS guidelines, but we have some language for that. And so you can have a really efficient psychiatric consultation that can help support collaborative care. So one of the things that I have always strongly advocated for was sharing outcomes. We are convening a group now of researchers from across the country who are doing collaborative care so that we can pool our outcomes. These happen to be some of the concert health outcomes, which is really nice. I'm super proud of them. But what would be really meaningful is if we had outcomes from all of the folks doing collaborative care and we could pull them together and report out on them and be able to say what are the research gaps and start to fill some of those gaps. And so we've been pretty fortunate about getting about half of our patients there at 90 days. I actually have not changed our outcomes. We still look for that 90 days. We still look for that 10 points and really and sort of aspire to continue to keep those benchmarks. So super important to be able to understand what that looks like and continuing again to really work to get people below 10 and then below a score of 5. And oftentimes what we see in some of the outcomes is people kind of forget about that. They're like, oh, we got people below, we got 10 points down, or we had this 5-point reduction. But wait a minute, better is better, but better is not the best that we could be. And so a lot of times it surprises me when I go into practices and a lot of the providers don't even know the outcomes. They're like, oh, yeah, below 10 makes sense. Oh, below 5, like that wasn't sort of part of the collaborative care implementation. And that's so critical. We would never not know an A1C goal, right? Like we're really clear. We need people to get here. And so a lot of the problem is that we haven't been that clear. And then a lot of folks in the collaborative care space haven't been as clear or transparent with their outcomes. Like somebody that gets better that has a PHQ reduction, that's not really better in my book, right? And so we really want to sort of standardize that, be a little bit more public and start to think about some of these outcomes because you can get them, and I think people are getting them, and we want to learn. If we all come together, then we can all learn about what this looks like. So here's kind of what we've seen across the board. The women's health practices have been tremendously successful, not just with concert, but nationally. And we are actually getting about a third of those women in 90 days, significantly reducing their symptoms. Interestingly, many of them are not on medications. In fact, a majority of them were not on medications. Also thinking about older adults, really looking at older adults. Surprisingly, older adults do very well in collaborative care and actually have pretty significant reductions. I think we need to learn a lot more about adolescents and sort of what is effective for adolescents. We're seeing a little bit of a difference in depression versus anxiety. And we're seeing a lot more kids, adolescents come in with anxiety, big mystery there, right? But a lot more anxiety, so really looking at that. We are also seeing some percentage of people with Medicaid come in with higher scores, but actually sort of do as well over time. So lots of information out there. One of the things that I really wanted to look at was, are people doing as well face-to-face versus video versus phone in collaborative care? And so there's a couple of flaws in what we looked at because people switched and it's really hard to keep track of some of that. So it's a little bit messy. What we did find, though, was that people in the face-to-face actually didn't have as good of outcomes. And I have a theory on that, and that's because a lot of the time wasn't spent as focused on symptoms, and people got a little distracted. And so I think patients didn't do as well in the face-to-face. I also think in the face-to-face, you're more likely to have a weekly session that's like 45 minutes or, 30 to 60 minutes, whatever that looks like. And one of the things which you'll see a little later on in collaborative care is that it's not the amount of time, it's the number of contacts. And we see this over and over and over again. And so the contacts were less in the face-to-face. And so I actually think that's why. Interestingly, a lot of people wanted video to start, and then they wanted phone. And effective collaborative care, I can't tell you how many times I've done an intervention with someone over the phone. Let's sit, let's close our eyes, let's do this progressive relaxation, let's go outside and take a deep breath. My favorite collaborative care patient ever in my whole history of collaborative care is a gentleman who lost his wife, hadn't gone out, wasn't showering, who decided one thing he would do is open a window blind. And we opened it together over the phone. What do you see outside? What does it look like inside? What does that? And then he was going to have his coffee in front of the open window blind. Like, we did that together over the phone. So what actually happened, he had his coffee there, and then he's like, man, this place is dusty. I can see all this dust, right? And so then he dusted. Well, guess what? If you don't dust, you don't have cleaner. So guess what he had to do? He had to go out. Right? And so he hadn't been out. What happened when he went out? He ran into his neighbor. Guess what happened to his PHQ score, right? And so those are that's the spirit of collaborative care, and that's why the phone works so good. And so I think that's why you see the preference. It's convenient, but also it's just super effective to be able to do those things. And again, if you listen to nothing else today, like this woman came, she talked about collaborative care, that was really nice, but is this touch point thing? It is absolutely critical to the number of touch points. The first week should have a couple of touch points, 2 to 3. Same with the second week. The patient who has 5 10-minute touch points is going to do better than the patient who has 2 sessions, right? And I say this all the time to folks, and a lot of times I go in and people say, we do collaborative care, and I say, well, let me see your schedule. And if I look and I see people scheduled at a regular cadence or biweekly, I'm like, you're not doing collaborative care. You don't need to tell me anything else. I've been here 30 seconds, and I can tell you right now you're not doing collaborative care. Because the spirit of collaborative care is these frequent contacts, these touch points, right? And that's important. So if you're thinking about collaborative care, it is so important to build these in. And yeah, it's a little challenging because you have to figure out the scheduling, but it is what is tied to engagement and tied to outcomes most clearly. And I just looked at it across 120,000 patients in our concert, and I've seen it in other places. So super, super important. Now we're working on some of really looking at over 20. For years, we've told people, don't base your workflows on scores. So 10 to 15, we do this. 20 and up, we do this. Because it's never really been a good predictor to help guide what should happen in a workflow. And so also a lot of people have said, well, 20 and up, we refer them out or we do something different with them, right? And what we're actually finding is those patients do really well in collaborative care. And there's not much of a difference between how well they do and how well patients that have lower scores do. And so interesting to be able to see. This is probably one of my favorite studies that we did. Thank you to Matt Bowman and the Bowman Foundation, who are incredible. If you don't know Matt, he's like salt of the earth, phenomenal. And so looking at suicide risk, and I have said from day one, being on the Zero Suicide faculty, collaborative care is actually a higher level of care. Because I can talk to someone every single day, review a safety plan, practice a DBT skill, follow it up the next day, right? So I would say, how is a higher level, and I don't use higher or lower levels of care with collaborative care, it's an alternate level of care, and to say, I'm not sure actually how that's better. And so I kind of felt from the beginning, and we started doing suicide care from day one at Concert 8.5 years ago, and have found that we were actually able to reduce risk because of those frequent touch points. That's incredibly helpful for people. And so I'm not surprised that the University of Pennsylvania, that Kaiser, doing the same collaborative care work, had the same experience with their patients at risk for suicide. And I think we're going to continue to see this, and we're going to continue to build, because now one question for me is, okay, we're reducing risk, but does that really mean better, right? Like, what is better? What does recovery look like? And I absolutely feel like that is achievable sort of within our collaborative care construct, and so continuing to be able to work on that. So we are continuing to look at the outcomes, and we're continuing to look at that reduction of risk. So taking someone from high risk to sort of an at risk to a lower risk, and then somebody who has a history is always at more risk for suicide. So if you look at how we all came about it, Kaiser and Pennsylvania and Concert, we all had a little bit of a different sort of background in our study design, but essentially all using the core components of collaborative care and all tracking a risk reduction in some very similar capacities. Even though the models are a little bit different, the cores were pretty much the same. And of course, Kaiser wins with the number of patients because they're Kaiser, right? But still, the total number of people across the board, it's pretty impressive to see this demonstrated across 3 systems with so many lives being touched and so much reduction in suicide risk. Because one of the things we know is that we're not doing a stellar job of identifying people in primary care who are at risk for suicide. Like, we're still not there yet. And so the idea is, if we can continue to promote some best practices there and have people in collaborative care, we can actually do some effective prevention work and save some lives. So when we think about what probably all of you are kind of front and center thinking about some of the healthcare costs, you know, way back, the impact study showed cost savings. And I think we had a little bit of a gap in the research and in some of the data put out for quite a few years. Like, we're still talking about that impact study however many years ago. And I think some of the recent work put out, so the Bowman Foundation's The Total Cost of Care has some amazing data in it. The University of Pennsylvania, again, very active in this work, continuing to show some cost savings. And I think if there's some documents that aren't in here but are out there, North Carolina put out a roadmap that has some really good information. The blue in California, the blue in Arkansas has some really good data to put out in terms of costs. And I think we're going to start to see more and more of that as we go forward. And so that's something that we were actually really talking about. So this is an incredibly busy slide. Many of you have seen this. Again, from 2008, it's clear. It clearly shows us, right, cost savings. It has been the backbone of what we've shared for cost savings since it was put out. But one of the things now is we have a lot more to add to this. And I think some of this, like this, is pretty incredible when we think about the total cost and what we're starting to see. And so now when there's legislators or when there's plans that say, gosh, we're still thinking about this collaborative care thing, we now have quite a bit to be able to give them in terms of cost savings. And I love this UPenn study because really when we think about lower for the primary care group, right, then we want to start to think about how we're actually impacting some of these other subgroups. So like the substance use disorders, I actually think you're going to see a pretty big increase in the number of organizations and practices that are using collaborative care for substance use disorders, particularly in MAT practices and some of the others. And so I think we're really going to be looking at cost savings there, but also outcomes and what does that look like. I think you're particularly in the next year or two, you're going to see a dramatic increase there and sort of what that looks like. So this was actually a little bit of a project of mine. I work with an IPA in Western New York, and one of the things that I always hear is that small practices can't do collaborative care. Doesn't work. And we actually wanted to show the world that that was not necessarily true. And this is in Western New York. These are all what we would consider small practices. And I can tell you what we found. We found really good outcomes. And the way that we launched this practice, and one of the things that I can say that we've learned a lot about is implementation. If you ask, and a lot of times people ask me, well, why do you think some of this went wrong? I talked to, I can't remember who it was, some folks in Montana. And it was like, you didn't launch well, right? Like, we've learned a lot about implementation. And there are practices that I know have been implementing collaborative care for 10 years, literally. And I call them, there's a place, it's a lonely, lonely place you never want to go. It's the land of perpetual launch. So I am too old to go to the land of perpetual launch. If you want to go there, you are welcome to go there, but I will not go with you. And so I now, maybe because I'm older and crankier, or I'm just wiser, right, is that we don't do implementations like we used to anymore. And I am very clear from day one, here's your pro forma, here's what we need to do, here's how many patients are going to be self-sustaining. You have one care manager, because it doesn't pay to take time to predict how many care managers you're going to need, because every CFO looks at that and goes, I'm not hiring 32.1 care managers. That's not happening. And so I don't actually bother to do that. I don't actually care about those predictions. Give me one care manager, give me one practice, and I don't want to hear a pilot. I don't want to hear one provider. No. Practice, one care manager, and let's roll. 30 patients the first month. And I don't care what we have to do to get there. I will talk to you every morning, and we will figure it out. Rapid cycle, I'm a rapid cycle gal, I'm not a PDSA gal. And so we're gonna figure it out, right? And we're gonna get to 30 patients. And guess what we're gonna do month 2? We're gonna get to 60 patients. And you know what's gonna happen? The care manager's gonna start to figure out collaborative care. The primary care providers are going to say, I kind of get this now because I have enough people in it. The billing people are going to go, oh, crap, better figure this out because I got double the amount of claims coming next month, right? 60 patients the second month. Now what's happening? Care managers really figuring it out. They're not going to quit because they're not sure what they're doing, right? And they're not getting other duties because ultimately what they do is quit then, right? So now they're figuring it out. Guess what happens month 2? Most practices are self-sustaining in month 2. So now we're there. Billing people are getting some claims back. We can know if we got our pro forma right. We can know if we need to adjust it. We can know if we have some billing problems. And guess what happens month 3? 90 patients or 75 for peds. Now we're up and running. Care managers got their groove on. We've solved problems, right? And we've got our billing pretty much down. And guess what? They are off and running. Off and running. And that is exactly what we did for all of these Western New York practices. And what happened? They were up and running. The caseloads were up and running in that time frame, pretty much over time. And then what happened? So what they found was, guess what? Less than a year, 90 days in, they were already showing a margin. 11 months in, had a pretty healthy margin, right? And so, really helpful. And actually, they were self-sustaining at fewer patients than we initially predicted for them. So, incredibly helpful. And what did they actually find? Significant cost savings in their IPA, which is something else we're going to put out. So this was a brief we put out just recently around a successful collaborative care launch. Glad to share it. And then we're doing a second paper on the outcomes they found where they saved emergency room utilization, they saved total costs, and they had reduced utilization and increased cost savings. So this was Western New York IPA, so it can actually happen. So some of the things that we want to try to think about is engaging all of these folks to be able to come together. And I want to thank all of you for the conversation today, and we'd love to answer some questions.
So, Doctor, I hope you don't mind. I'm going to call you Dr. Verna and not Dr. Little.
Okay.
We do that in my house. We have the first name.
Or just Verna's.
Or just Verna.
Okay.
So we have a lot of questions. Here's what I'd like to do. I'm going to share the question, but I'm going to actually hand the card to you because I want to give you two questions because we don't have a lot of time. And these are some great questions based on your presentation. So the first is in Massachusetts where payers are reimbursed for the collaborative care codes. 10 to 15% of practices are billing the codes. Payers are still doing reimbursement differently from one another. How do we solve this? As you said, and you pointed out in your presentation, the evidence is overwhelming, and it's been greater than 30 years. And great job sharing the outcomes. Yes.
Okay. So this really needs to be on the state level because part of the problem is the plans are going to reimburse a little bit differently. There's also big discrepancy. Let's take the 99494, that add-on code, right? This plan pays one, we found out in something recently, right? Many of them are paying two, but CMS guidelines are actually 4 now. And so what we want to try to do is at a state level say, here's what we're going to do. We're at a minimum, and I'm not recommending this, I would like for you to aim higher. You seem like aspirational people, so we should aim higher, right? But let's just say 100% of Medicare. Everybody has to pay it because even in states where the Medicaid rate is 100% of Medicare, if the commercial plans pay crap, then guess what? Practices have a really hard time making it go. And so the state has to say the floor for everybody is 100% of Medicare. We're going to follow CMS guidelines and say 4494s. So there's some consistency. And I would also say there needs to be some consistency around guidance for providers. Oncology, cardiac, some of those other specialties do amazing collaborative care work, and they should be included in that guidance.
Great. I'm going to ask two questions together. Are there any differences in using the collaborative care model for pediatric versus adult populations? That's one. And are there any federal policy changes you would advocate for to increase the collaborative care model adoption?
Oh man, that second one's like a whole day. So for pediatric, I would say lesser caseload for sure. I would also say it's pretty hard because there, particularly the 6 to 11 population, there aren't a lot of researched outcome tools that practices can use other than the pediatric symptom checklist. Like, there's still gaps, right? So I think it is a little bit hard. It's doable, but I would like to see that developed a little bit. But now at least they have a foundation. I would also say we're still not seeing some of the child health insurance plans pay for the collaborative care codes, and that actually is also an advocacy issue and a state issue, but we are seeing that kind of across the board, and that's incredibly problematic. For advocacy, I think at this point we have 34 states that have passed the codes, and we have learned what works. And we could tell you, we could sit with you, we could hand you documents, and we could tell you what works. You have to pay over Medicare. That has to be the floor for the state. You have to follow CMS around the 494s. You need to actually think about how your FQHCs and your CCBHCs are going to build these codes. And you have to make it doable for them. Please do not take those G codes. Those G codes do not help. That minimum of 60 minutes, those G codes, use the CPT codes for them. And interestingly, when we talked to CMS, we said the states think they have to use those G codes, and they're like, why? Where'd they get that from? And so you could actually use the CPT codes for your FQHCs, which is incredibly important. I think we now want to think about changing some of the guidance that everyone on the care team could talk to someone about that verbal consent. We want to try to have some clearer guidance around parent and collateral engagement to sort of end some of that confusion. So I think we also need to get rid of that mid-level provider, because if I'm a nurse practitioner or I'm an MD, the cost of my psychiatric consultant, the registry, the care manager does not change. And so we need to take away that lower reimbursement. So those are just some things off the top of my head, but I'm sure I have more and would think of them had I had more than one cappuccino.
Thank you. I'm going to double up questions again, just so we can get to as many as possible. And you're really good at taking more than one question. If the collaborative care model was considered a preventative service, thus no copay or cost-sharing fees, how would this promote the expansion of the collaborative care model? That's one. And have you engaged psychiatrists to participate in this model, how do you engage psychiatrists to participate in this model, given the high number who do not take insurance?
So the first one first. Can I just see the first question for a second? Yeah, I want to make sure I get the whole thing. So we've actually talked a lot to the preventative task force. If we were to get rid of the copays, it would be a game changer. We're actually working on something now to have the codes carved out for the high deductible plans, because what happens is that really is such a barrier for people. It really is. And the copays, even though the monthly case rate does make these services more accessible to people, it is still a huge barrier. And I think if we could reconfigure, and kudos to the Blue Plan here who doesn't have the copay, which thank you. I offered to connect him with every Blue Plan in the country so that we could, he didn't know that. I just said, could I tap you? That's what that really meant. And so I think if we could advocate for that statewide across the board, that would be a game changer. Yeah. And then, what was the other? Oh, the psychiatrist. More and more, CFHA now is working on a certification for psychiatric consultants. More and more residency programs are actually training around collaborative care. So we do find a growing number of psychiatric providers that actually want to do collaborative care full-time and do collaborative care full-time. And so I think actually I don't want to say it's not hard, but it's less hard to find psychiatric providers now that are really interested in doing collaborative care.
Thank you. Next question. What is the process for managing touch points for English as a second language patients?
So, like any other service, you have to speak the language your patients speak. And so continuing to be able to think about how we're providing services to individuals that English is not their first language. And I know it's always a struggle to be able to find providers that speak the languages of the populations we're caring for. But collaborative care is no different than any other service you're providing. I think the model would look the same, and you would just need to make sure you have the right staffing. That would be mine.
Makes sense. Do the findings support this model in a practice with 40 to 50% of patients with severe and persistent mental illness, SPMI, as well as overwhelming SDOH needs?
So interestingly about the social drivers, we actually found that individuals with more than 2 social drivers came in at a PHQ score of about 3 points higher, but no change in anxiety. Their anxiety scores were the same. I actually was kind of surprised by that because it made me a little anxious just hearing about some of the stories. So I think that actually is not as much. What we're finding is that collaborative care really puts a system in place to care for people and track outcomes, right? And for the bipolar population, for a lot of folks who have significant histories of trauma, people at risk for suicide, they actually do really, really well in collaborative care. And also what we do for a lot of practices is we do what we call treat to target. And then treat to transition. And so figuring out, coming up with a plan, and then treating someone while they might be transitioning to a different care. You know, maybe it's a day program, maybe it's somewhere else. But I actually think there's large populations in many of those settings that would do incredibly well in collaborative care. I also know that individuals, you know, we spend a lot of time telling people what they didn't do, right? You didn't lose weight, you didn't follow this, you didn't do. So we spend a lot of time telling people what they didn't do. And a lot of our people don't have a treatment success. Well, celebrating those successes in those early contacts in collaborative care is incredible for our patients. And giving them a treatment success is incredible. And so, oh yeah, I can have some ability to have an impact on my symptoms. I am able to feel better. What does that do? It makes them more likely to go and stay to other levels or models of care. And I've seen that over and over again. And so I would say there's actually a huge role for collaborative care in that setting.
Thank you. This is the last question I have that's written out. You mentioned expanding collaborative care to address patients with more severe illness. In this area, this person said, I find that PCPs generally feel that antipsychotics and mood stabilizers are out of scope for them. Is that the case elsewhere? And if so, how would we try to shift what is in the scope of primary care? That's the first part of the question. And then behavioral health activation is the staple of the non-medication interventions for depression. Do they need to be different for anxiety, PTSD, et cetera?
So one of the things in terms of engaging folks, let me take the behavioral health or the behavioral activation question first. So behavioral activation is actually evidence-based for lots of different diagnoses. Turns out it works on husbands and family members too, in case you were wondering. But it actually is incredibly effective because that's like, what could you do today or tomorrow to feel less sad, right? And so building upon that. So whether someone is on medications or whether they're not, it's incredibly effective to be able to set those goals. And you know, there's a huge misconception. I would say some of the biggest misconceptions about collaborative care are that it's these brief interventions, which is very true, but that it's not treatment or it's not therapy. What is therapy? Therapy is someone who is qualified to treat a mental health diagnosis with evidence-based interventions. I do that all day, every day in collaborative care, right? And so I think we often overlook that, and that talk treatment or therapy is actually a treatment choice in collaborative care, and behavioral activations is one of those evidence-based practices that is, you know, sort of like magic. And then what was it? See, this is why I should have had more than one. With the severe illness. So we're doing this project now with PTSD and bipolar with the AIM Center. It's a PCORI project. And I said right from the get-go, primary care providers are not going to be comfortable prescribing bipolar medications. Like, I can just tell you that right from the start. And so, but one of the things that we're doing is if we do a confirmatory visit, like a diagnosis confirmation with a psychiatric provider, and someone is stable on meds, then the providers are pretty comfortable with frequent consultation or the availability of consultation to sort of continue those meds. And that's kind of what we're finding. And that's like with any other, you know, someone on medications for cardiology or, you know, some other medication. So that actually has been pretty successful. But I think, and, you know, many primary care providers would not be on board with starting, you know, mood stabilizers or some of the others, and I think that's fine. We actually can build collaborative care to support them.
Thank you. Can we have a round of applause?
Thank you.
Dr. Verna Little, masterclass in the collaborative care model. I'm going to invite Michael back up. I think we'll take a break before the panel.
Exactly. We'll take a 10-minute break. Coffee and breakfast is still out there. And thank Ashley when you see her. Thank you, Michael.
Okay, we're going to ask folks again to be seated. We're going to get started. For the sake of time, because we are running behind, I'm not going to go into the bio of these phenomenal panelists that we have here today. But I wish I could, because it'll give you a sense for their background and their perspective of the questions, the issues that we'll talk about today. So first up is Kiame Mihania, Dr. Kiame Mihania, Undersecretary of the Massachusetts Executive Office of Health and Human Services, Dr. Trina Chang, Medical Director for Behavioral Health at Mass General Brigham Population Health Management, Patrick Aquano, Doctor, Chair, Department of Psychiatry, Leahy Hospital and Medical Center, Medical Director, Behavioral Health Integration, Beth Israel Leahy Health Behavioral Services. Gregory Harris, Doctor, Senior Medical Director for Behavioral Health, Blue Cross Blue Shield of Massachusetts. Give them a round of applause, please. Okay, so we had a phenomenal presentation from Dr. Little, and we have some questions we'd love to pose to you, the panelists today. So I want to start with you, my good friend, Kiame. For those who don't know, Kiame and I have a long history when he was the head of Lynn Community Health Centers, and now as a phenomenal leader in government. As a long-serving family physician and former leader of a community health center that integrated behavioral health and primary care for its patients, will you explain what an integrated practice means, and maybe particularly from a FQHC perspective, and how different is the experience for patients and for practitioners?
So I'll try to keep it short. I think it means different things, different depending on your setting, and definitely health centers can have different perspectives on it. Where I am at the Lynn Community Health Center, so I still practice and see patients there, and mostly I see patients within a team that's centrally dedicated to folks who have substance use disorders. It means that I have a Psych NP colleague that sits in my space. It means that I have several therapists that sit in the space. It means that we have recovery coaches. It means that we do have a BH navigator. And so I think that what it means, and when I was thinking of Dr. Little's presentation, is that the number of touches that our patients have with different members of our team is pretty extensive. So even a patient that's stable, that only sees me once a month or once every 2 months, could end up having 1 or 2 touches every week with somebody in the system as they need it. And one thing that I'm sort of fond of saying is that our patients theoretically come to us because they're looking for healthcare, but what they're really looking for is a loving embrace within society, particularly if you've been a user for many years. What you're really looking for is a form of human relationship that is not exploitative and that is not difficult. And so I think that the ability to have different people at different levels who offer different things, but all within the context of essentially offering a relationship. So I think for the patient, it means that instead of just relying on your, like, I may be a nice guy, but there's lots of patients who don't click with me, you know, and the idea that they could have a case nurse manager or a therapist or a recovery coach or a psychiatrist or a psych NP that could end up being actually their main relationship means that they have access to really this plethora of relationships. And I mean, I have the luxury in the sense that my patients I've known my people, some of my patients are known for 10 years. And so it's a very regular relationship. And then so they have access to this incredible web, this incredible richness of people that can offer different expertise in terms of helping them figuring out what their life is like. I think it's just a world of difference from a patient perspective that, number one, there's always somebody you can reach in real time. I mean, that's sort of like the, right? And if you can't reach the person you're looking for, you know that you can call. It's so common for me to get a text from my therapist colleague says, hey, so-and-so sent you a message through my chart and you haven't answered, and they really want to know this, right? Like, and so the relationships are not just one direction with us and the patient, but also amongst ourselves. It's so easy to be able to turn to a BH specialist and say, you know, this person was stable for 2 years on this combination of medication, but this thing has happened and I don't know what to do. And they just give you an answer quickly because it's an established relationship and, right, they're not worried. And as any of you guys who are professionals know, the record keeping really does not reflect what people think. So just reading the notes is not necessarily enough to sort of know what your colleagues are thinking. So I think I can't imagine practicing somewhere that wouldn't have integrated behavioral health. And actually, when I was CEO at the Lynn Community Health Center, we were given money to start school-based health centers, but we didn't get enough money all the time to start integrated. So I had to choose either behavioral health or medical, and invariably we always chose to start with behavioral health because we really thought that that's the foundation of what a healthy lifestyle would be like.
Stuart earlier made the analogy of the behavioral health and primary care integration is like a married couple living in different houses. But I'd say for some health centers, many health centers in this country, they're in the same house but in different beds sometimes, which is the challenge. Second part of the question to you, Kiame, how does your experience as a family physician practicing integrated care inform your policy-making work at EUHHS and Mass Health?
I can see Mary Lou Sutter's looking up from her phone now. I would say that there's no press, correct?
There's no problem.
I would say that, the learning curve in government has been tremendous. I would say that if there's one weakness that government has is that most people who go into policy work are people who love policy. And you hear people, you've even heard, I think Ayanna Pressley, who said, policy is my love language, right? Like, and that is a very common sort of attitude among people who make policy. But they don't necessarily think about implementation. And like, what does it mean to have this policy that looks great as a regulation, but what will it look like when, some practice gets it and be like, oh, how am I going to implement this screening? Or how am I going to do this add-on? So I think my perspective has really been that I really think of it as how will it be operationalized? How will it be taken in? And how will the people that are being served experience this particular policy? As those of you who've worked in government know, a lot of times you're putting in place policies and regulation in response to some requirement that's put onto you by somebody else, a lawsuit, the federal government. And so it's sometimes difficult to be able to think of a policy that you're putting in place in response to an imposition, and at the same time, think of it in terms of how will the client experience it. So I think that's probably what I bring most is the ability to know what it will feel like in terms of the people who are delivering that service.
Excellent. Before I go to the next question, I was a DJ in college. Many people don't know that. I went to Macalester College, and there was actually another graduate of Macalester here that stopped me. So I'm prone to give shout-outs in the middle of a forum. And one shout-out I want to give, because I mentioned earlier about being thankful to live in Massachusetts. We talk about data, is Chia and Lauren Peters. Can we give her a round of applause, please? And her phenomenal team. Dr. Chang, as medical director for behavioral health, who is leading integrated care efforts and adoption of the collaborative care model, would you describe your implementation experience? How would you describe your implementation experience with the model?
Okay. So I don't know if I can be quick about it because it was a 10-year process. If you want the short version, I would say long, roundabout, evolving, but hopefully we got somewhere, made progress in the end. So I would actually say that we actually didn't even start out intending to do collaborative care necessarily. Our mandate was actually from population health management, that they wanted us to consider what would be a good population health approach to mental health. And so we ended up deciding that from a population health, almost more that sort of preventive to the earlier phase intervention, that actually collaborative care for depression was going to be one of the most effective things that we could do. And so we decided most of all collaborative care, but we also realized, this was 10 years ago, a lot of practices weren't even screening for depression, so we knew we had a lot of ground to cover. So we ended up sort of taking a two-part approach for buy-in purposes and just, for supporting our primary care doctors. So we decided that we would do collaborative care as sort of advancing the tip of the spear, but thinking of something for everyone. That was the words of Eric Weil, who was our, our director who was overseeing us. So the idea was that we would try to launch collaborative care practice by practice, sort of like in waves, and get people sort of used to the idea while building the infrastructure, gaining experience, because you don't go from 0 to 150 in a day. So gradually doing that, and then the thing that we would try to do to bring everyone up, to uplift them, we would try to do things to promote screening, basic management, training, sort of suicide workflows, and a MAPAP-like service, actually. If people know the Massachusetts Child Psychiatry Access Project, excellent resource for pediatricians, where you have curbside consultations, the ability to sort of see people, resources for people. So we tried to implement those. So basically, population health management funded this. This was before billing was possible. We were really fortunate that MGB, then Partners, was willing to fund this. So basically, over the next couple of years, we just hired teams, hired collaborative psychiatrists, got people sort of trained up and sort of brought people in there. We did eventually reach about 75 to 80%, I would say, of our primary care practices. Then there were various changes at MGB, or scope narrowed. There was this thing called a pandemic, unfortunately, that hit in the middle. And, but at the same time, billing became possible about halfway through this journey. And so at that point, we did switch over to a vendor to help us with that billing process. And I think basically at this point, it's pretty well accepted at most of our employed practices. And with Concert, we're actually expanding to pediatrics, and we're also expanding to central Massachusetts and thinking about New Hampshire.
Excellent. What needs to be in place for successful adoption to establish and sustain the program?
Yes. Well, a lot of things. I mean, I would say that obviously leadership buy-in was really important, because when we started out, we did have leaders who were willing to fund this, who were willing to subsidize this treatment. And also we have leadership buy-in on a more local level. We always think about the high-up people, but you really need people on the ground to be the people who are your ambassadors, the people who really are convinced about it, to help you with that argument, to give you that feedback. So that's the medical directors at the local practices who are really important, your champions. Operationally, you also really need to think about the startup funds. I think that's one of the things that's really helpful about some of the projects here, like the Bowman Foundation, where you provide the funds to help not just with the ramp up when you're trying to get people sort of, their caseloads full, but there's a lot of operational work to change, your billing systems, to be able to chart, to do your workflows. Like if there's a crisis that happens, what do you do with a patient who says that they, are having thoughts of suicide? That's really overwhelming, I think, for a lot of places. So you needed those workflows. And then I think also data, infrastructure for data. And I think another important thing that, I think wasn't really conscious of till later, you really have to have an appreciation for how it fits into an entire system. Because the fact of the matter is, collaborative care addresses a portion of the patients. There's still a lot of needs in this system. You need to think about what are you going to do with the people who can no longer be managed in collaborative care. You also have to think about triage. How do you know where people should go? You have to think about the resources. You also have to think about like the crisis questions. Is a collaborative care team going to manage that, or is someone else? And then I think understanding of finances, realistic expectations really helps. So.
Thank you. And Dr. Aquino, with 10 years of experience leading behavioral health and primary care integration at the BILH primary care system, will you describe your on-the-ground experience with the collaborative care model?
Sure. So I'd say my actual experience is probably closer to 15 years at this point. And I think it goes back to my work. I'm a consultation psychiatrist at heart, so I do psychiatric practice, but within medicine and surgery, and always have been. And so when we first started, it really was being that person in the clinic. So, as you talked about, kind of that in the ground, working alongside PCPs, taking care of patients directly there and seeing that. And as around that time, we're starting to see an impact from the collaborative care work out in Washington and see where that can move to. And that's when I first started to take that on. And we built that out of a small group. We would go for some grant funding to kind of get that alongside, and have built that over time. There have been some fundamental shifts along the way that have really propelled this and accelerated this. And unfortunately, it hasn't been the science, right? So we've had over 100 randomized controlled trials for over 20 years that have said this is the right thing to do. If this was antihypertensive or a way to treat diabetes, like we'd all be doing this and not having this large meeting here to talk about how we're going to do this. But really, so it has taken a lot to get there. We've been really supported to bring this together and continue to evolve over time. And Dr. Chang mentioned a lot of the hurdles about that. But I'd say that the biggest thing is around partnership. So it's being able to be on the ground in a practice, know what it is like to live as a primary care physician, the challenges you see, the patients you're taking care of. And I'm not a primary care physician. And I learned a long time ago, I should not come into a primary care practice and tell you how to be a primary care physician or what you need to do, but really hear from you what your needs are and help you figure out how we can best help you help your patients. And that's been our approach. It's how we've been able, I think, to effectively get into all the practices where we are. And we're at over 80 practices now across our health system, and that over the years has come through the help and support of lots of other groups and entities here in the Commonwealth that have made that successful. But it is really about understanding the needs on the ground in those practices. And though we're in 80 practices and we've got, we think, a great model and we have fidelity to all of the CMS rules and everything like that, every implementation is different. Each of those practices has its own unique culture, it has its own individual approach to the patients, and even within the providers in that practice, they all take care of their patients very differently. And so we have to figure out a way to use the model, adapt to the needs that are there, and build into the workflow that's going to be successful for them. And as Dr. Chang mentioned, it doesn't care for everybody, right? So everybody that has needs, this model and the way of treating them isn't going to be ultimately effective for everybody. And so that's been a lot of our other work is how do we continue to expand and bring a continuum of care around people where this is one part of what we can do. But in a health system, we want to do more, and we want to figure out other ways to connect those individuals and to care if they need it and how we can help do that. So it continues to be a labor of love. I'm a practicing psychiatrist. I consult all these practices. I still do this on a daily basis. And it's something we continue to do, and we're continuing to grow across our health system to be able to do that.
80 practices, and as we often say, the health center movement, but it seems true here as well. If you've seen one practice, you've seen one practice. Can you discuss your successes in adapting, adopting the collaborative care model as a system innovation, the framework for operation and sustainability, and any other types of integration, specialty care, digital, and other innovations that you view as complementary to collaborative care?
Absolutely. I think for us, the implementation part has been the fact that we have lots of experience. I think I was talking with Dr. Little earlier. The biggest hurdle is around implementation science, and I think if you're able to get in there and do that, you can replicate it. And that, I think, has been our success, right? We've learned from our mistakes. We've learned how to become more efficient. We have a team that does this. And so we can, we're not necessarily turnkey, but we're pretty darn close. Where we can come in and we can assess your practice, we can tell you what we think should be ratios, we can help you identify all the patients that you probably aren't finding yet, that you didn't even know about, and we can, from the day one, begin proactive outreach to engage those patients with you and identify them. And a lot of that has come from significant amounts of efforts around screening, when just the absolute idea that we can screen people, and then continue to help educate that beyond screening, now we need to follow and track people's outcomes, right? And that's a change in workflow. And so we have to be able to figure out in your workflow, in your practice, how are you going to do that? If you're not aware of that, how do we teach you and train you to do that? And how do we build trust, right? These are strangers coming into your practice. You have a long established practice and a good group and culture. How are you going to welcome new people into that? How are they going to build trust so that you can have those close relationships, that easy communication to be able to do that? And as I've mentioned, we understand and recognize and hearing from our primary care providers, thank you, we love collaborative care. I don't know how I could practice any other way, and I still need more help. Right? I still need more. And so we're trying always to find other ways to do that. So we are building other services in and around that. So One is kind of faster access to some consultation work, so direct care consultation from psychiatry and how that happens and how that could occur. We're also looking about how we can build in some digital health tools, right? So we have a partner in our system that has an evidence-based treatment model around using digital navigation and digital mental health tools we have experience with. How can we leverage that for folks that maybe don't have as high a level of acuity or a high level of need to have a lot of touches through collaborative care? How can we use digital health and some self-directed tools to support them and free other scalability in terms of the collaborative care model? The other is we're continuing to expand into other areas, right? So as we're seeing evolving evidence, one, into more severe and persistent mental illness or severe needs into other communities, whether that's pediatrics, women's mental health, specialty care services, we see the power of this model being able to affect these other communities, and our patients enter the health system and they touch care in lots of different ways. Primary care is the main door, obviously. But there's other places where we can capture them, and they have relationships that we want to build upon. And ultimately, it is finding where in this healthcare system you have a close relationship to a provider. If we can meet you there with them, we have the best chance possible to lead to success. And that's really where we're trying to find it. Ultimately, it is we want to go where our patients are and meet them where they are and bring them the best tools we can.
Excellent, thank you. Before I go to the last question, I want to invite people, please, to come to the mic if you have a question. So I'm going to encourage people to start thinking about anything that sort of triggered thoughts for you or some things you'd like to bring up with the panel. Last, Dr. Harris, as a physician who practiced in primary care and psychiatric specialty care settings and now provides medical leadership to Blue Cross and Blue Shield of Massachusetts, will you describe the utility of the collaborative care model as an evidence-based practice of BH and PC integration and the basis for innovation in meeting the needs of certain patient populations?
Thanks. Yeah, I've described my path actually to Blue Cross as being disintegrated from primary care, because I practiced in primary care 30 years ago, and it was all grant funded. It was, the funding mechanism really wasn't there. And so I went from one primary care setting to more of a private practice primary care setting. Things sort of changed, landed then at Blue Cross. And I think one of the things I've learned is this sort of coding and billing structure is really foundational. What gets paid for is what gets done. If there's no mechanism to pay for something, it won't get done, or it'll get done inconsistently and cause problems there. So that's one of the elements that led me to even working at Blue Cross and trying to figure out what was covered in a system like that, in the Blue Cross system. And one of the utilities that I see of collaborative care is really, fundamentally, it's a population-based model of care, which is very different than the fee-for-service model. So a lot of what I'm hearing people talk about multiple touches and how do we get multiple touches, there's a lot of innovation in mental health space now that I've had the privilege of meeting lots of different companies doing lots of things. They all want to get paid for this and that. But embedded in the collaborative care model is over this month, a lot of different things can happen. You have a staff person doing that. You have a practice that is really, they're being paid to do collaborative care services for those patients who need them. But to do the service, you have to screen the whole population. So we see a lot of practice. I see a lot of variability within Massachusetts and then across the country. Blue Cross Blue Shield of Mass is a local Blues, where Massachusetts, not-for-profit company, but we have members all across the country, and you see that variability. And so to be able to link a psychiatrist and get that consultation and then have a care manager and have that all built and be screening that population, I think we're only at the very beginning of it. But what the vision for me is that everybody would be screened. Some of them would need collaborative care. Some of them would not. Some of them would need collaborative care plus something else. With Patrick, we've worked with, doing consults when somebody doesn't really need the whole collaborative care service and they just need a consult. The people need multiple things. They're going to need traditional care. They're going to need to have those pathways. But if everybody's getting screened and then everybody's really getting screened for suicide, that's a very exciting sort of research, that part of it. I see practices that are like, well, we'll do a PHQ 8 or we'll do a PHQ 2. That's not going to screen for suicide. That's as much a part of this model of screening everybody. There's a suicide epidemic. So sort of being a representative of a plan, there's the cost, there's the care, and then there's this epidemic of suicide that I see. The diabetes rates go up, we do a lot of things. What are we doing for suicide? There's this asymmetry, and so that's part of what my role, leadership in the company, is to sort of voice this stuff and have that become front and center.
Excellent. As a leader in the effort to create the collaborative care codes, would you comment on the utility of the coding structure
I love codes, apparently.
in supporting
Yeah.
and sustaining the collaborative care implementation?
Well, it's the most dry thing I do. I've spent a lot of years, 20-something years, doing behind-the-scenes stuff with the coding. I think these codes are really, they're imperfect in many ways, but these are Category 1 CPT codes that are valued in this RVRVS system that everybody doesn't understand and doesn't like. I don't love it. It's imperfect. But it's the system that goes across specialties. And there's a lot of things we do in mental health that are in a different code set that doesn't get valued that way. So when I hear like, well, we should pay what Medicare pays, well, how would you do that for an IOP? You wouldn't, or even ABA services. A lot of services, there aren't Medicare values because they're not in that fee system. And so getting codes that are population-based, that have a primary care doctor who bills, and a psychiatrist who consults, and a care manager who's staff, who is an independently licensed person, and that hours, it's complicated. It's why people are like, I don't know what I'm supposed to do with these codes. But getting that through this process was a minor miracle. And so to have that code and then it's valued, is it valued properly? Is there press here? I think it needs to be valued more, but there's a mechanism to bring that back to the process to say, we have more experience with this code. When it came through the process, the first time there wasn't a lot of experience with the code because the code was new and it was complicated and primary care was involved and psychiatry was involved and nurse practitioners. There were a lot of people involved in trying to figure out that value, and so it was the best approximation at the time. So I think it's foundational. I think it's imperfect. I think it can be built upon, and it's better to have the foot in that door than to not.
Excellent. Thank you. Can I get questions? So I'd love to have folks go to the mics with questions for our panelists. Puts pressure on me because Michael said I was doing the Oprah thing, so I need people to actually ask questions.
Great. Okay. I'm Senya Johnson-Bembe, Director of Behavioral Health at Greater Lawrence Family Health Center. Thank you all for this great conversation. As a behavioral health provider, I'm a pediatric psychiatrist by profession. The dialogue today is leaving me a little bit confused. And I'll tell you because I came to this work looking at integrated care as the ultimate aim. But the throughway to that was collaborative care. So in the definition of behavioral health and psychiatry in mental health world, collaborative care is paralleled care, and then integration is immersed care. So maybe it's just a matter of semantics and language, but just so that I can sort of frame my question that you all understand, one of the things I'm seeing at a family FQHC where I'm housed is that it appears as if behavioral health is not integrated or not collaborative. Primary care is capitated. Behavioral health is fee for service. Is the dialogue or the conversation we're having today to suggest that we're moving in a place where behavioral health is going to now be capitated? Or is there some clarity that we need to make around how we're going to really review behavioral health services in an integrated or collaborative care model?
It's a complicated question. It's a multi-part complicated
Nice way to
question.
set us off for the question.
Yeah. So maybe I can start. So I think this is a sort of a both and. There's a sort of fee for service traditional mental health, what I sometimes call the New Yorker cartoon of a, person in an office, and that's what people have in their mind. Collaborative care isn't that model, and it's telephonic, it's consultative, it's population-based. So I think part of what we're trying to do is talk about that model and how that facilitates things. I think that some institutions, there's a lot of integration in many ways, and others there's less of it. So I think the collaborative care model and having that more universal in all primary care, I think is part of the goal. It's not going to be sufficient in and of itself, in my mind, to what's traditional mental health. Whether it's capitated or not, I don't really have an answer to that, because that's probably plan dependent, whether something's capitated or not. But that's how I see the model fitting in.
I'd say that's a great question. I was at Greater Lawrence for 10 years, so shout out to Greater Lawrence. And my wife doesn't like me to remind it because she has a different name from mine, but she still works at Greater Lawrence. I would say that's part of what I was getting at. I was talking about it looks different in different settings. If you probably remember the SAMHSA 6-step grid where it started with like nobody, lone cowboy, and then it was like you're all eating at the same table, right? So I think in general people, I would imagine that most people think that the integrated model would be wonderful, like meaning where you're using the same EMR, you're using the same office, you're using the same staff, right? And so you're really integrated in that sense. But I also think that having promoted this for like decades, I think people have reached a point where they're thinking, well, the system is not supporting integration. So what are things that we can do within the current context, within current resources that have been proven, that have demonstrated feasibility? And I think one of those things is the collaborative model, right? I think at least that's how I think of it in those terms. In terms of capitation, so I'll put on my Mass Health hat a little bit now. One of the reasons that the subcap was primarily primary care is that at that time, I don't know if it's changed, I don't think so, but at a time there was no other state that has implemented a subcap where they blended in behavioral health in primary care. So it would have been a brand new thing, and as any of my fellow people here who've been leaders in places where the subcap was put in place, there's a lot of mistakes that happened. And I think that at least at the Mass Health level, there was this fear that if we rolled in a subcap primary care at the same time as a subcap that included behavioral health, that we would end up destroying things because we didn't understand it, we didn't know how it was going to work. And there was enough stigma against behavioral health that just the step of bringing parity in payment within Medicaid for behavioral health was like a humongous step. I think people are still trying to think about what does it mean if it's team-based care? What does it mean to have capitation? What would a payment methodology look like? But I think as much as there's consensus that integration is where we want to go, there's not yet emerging consensus on what the best payment methodology would be for such a model. And I think you've heard Dr. Harris talk about the code and how it doesn't quite fit, it gets really complicated. So I would say that I agree with both and, but I would also say that we're still thinking about it, right? Like what does it really mean to have parity between behavioral health and not? What does that mean, and what are implications for a system? I was just talking with Donna Marsh about this before. Maybe it's difficult because what we're talking about behavioral population health in terms of behavioral health doesn't fit in a break it and fix it model, right? Like maybe the problem is that we've built our whole system on a break it, if it's broken, go fix it. And what you're really wanting is like a preventive model. Well, what would that look like? And are we still talking healthcare? Are we still talking CPT codes when you're starting to talk about food and transportation and education and all that? So, but it's a great question. But I would say that it was the main question that drove me out of practice and into policy, which was what does optimal integration look like in terms of coding, in terms of policy, in terms of Medicaid, in terms of commercial plans, in terms academic medical centers? Like what does that look like? If there was like one question that really drove me out of practice, was my disappointment with what the on-the-ground answers were.
Thank you. Trina, Patrick, anything you want to add to it before?
I want to say, so I do understand that dilemma between feeling that you wanted to do integration and it's sort of a parallel pathway. Would be happy to talk with you afterwards in way too much depth and bend your ear that this panel wants to hear. I think that I practiced as a sort of a psychiatrist that was sort of co-located on the 4th floor of a community sort of health center where primary care was on the 2nd floor. I've been an embedded psychiatrist directly in a practice, a collaborative care psychiatrist, and it is hard to get there. We are not level 6 yet. And I think there's a lot of factors kind of drifting us backwards. One thing I might think of is that I actually sort of feel that it's more of a spectrum, that collaborative care is for a portion of people. My work as an embedded psychiatrist or a specialist psychiatrist is a little different, but I can sort of see the flow back and forth. As a collaborative care psychiatrist, I can say this is where you can go, this is where you can go. We can do a lot of other things, I think, to help promote that embedded, integrated feeling, so where I'm on the 4th floor, it doesn't totally feel integrated, but where we're actually sitting in the same place, saying hi to the same people, using the MAs, so we can actually do those things. We can use team chats to sort of allow us to get that feeling of being able to communicate directly, for example, really available even when we're remote. So I think, there's things that you can do to get there. There's a lot of backsliding because we are really set up, like space-wise, practically, funding-wise, to split it up. But, if you can keep swimming uphill like the up water like the salmon do it, so we can do it too.
The piece I would also say is we can't emphasize enough the adoption of the codes providing a payment mechanism for this to occur was really transformational. The reason this has accelerated as much as it has is, as Greg mentioned, like there's payment for it. And I would say when we look at the science, collaborative care is more effective and efficacious when we compare it to parallel, co-located care, all these other, when we look at the evidence. But in the real world, in real clinics, it's variable, right? So some clinics, however you define integration, can be really successful at the patient level and for the providers. And I think collaborative care is a mechanism to help you get there, to build some foundation and some structure. It has some criteria of kind of how we might define integration, what are the keys to successful integration. But our experience has been even in other community health centers and other places, not just primary care practices, is that that level of integration is really variable. And you can be successful in places that don't have a collaborative care model. And that's okay. That's great, right? At the end of the day, is it working? Fantastic, let's do it. How do we then make it successful? I think the other piece that's been successful is we have been able to break down the financial silos between medicine and behavioral health. We think about it as a single revenue stream that also breaks down some of those divides. But it really is an and, right? In your setting, can collaborative care be helpful for most people? Absolutely. Is it the only way to success? No, not at all. And I think it is finding what fits best with you, your practice, what can be supported by the evidence, what is financially sustainable, and figuring that out together. The great opportunity is, we're here talking about how to get collaborative care, in lots of different places. In Massachusetts, we're so far ahead of the game from lots of other places, and there are a number of resources and partners here to talk about what that's like and what that experience is, so that you can craft whatever works in your setting, in your community.
Thank you. Question?
Sure. So Dr. Harris, you said something that caught the attention of some folks over here around the RVUs, because that has been a little bit of a sticking point for a lot of organizations. And I'm wondering, we're intrigued by this idea of disconnecting from the RVUs. And you mentioned some examples, but we also don't want to get lumped with behavioral health, right? We want to are there examples on the medical side where we could move from the RVUs and sort of try to align?
Well, I was suggesting the exact opposite.
Okay.
We should be moving towards the RVUs and use that
Oh,
system.
interesting. Okay.
So, we have a fee-for-service chassis for whatever we're trying to do. So these codes represent a population-based model on top of that fee-for-service chassis.
Mm-hmm.
I think there's a lot of things we do in mental health. We do that we have other mechanisms. We have state mechanisms, state departments of mental health. I spent some time with my predecessor and I, who had conversation about doing early psychosis treatment and why does that not get paid by insurance reliably. And trying to get a code through that system was very difficult. And part of the reason it was difficult was the psychiatrists who were expert in that model just were like, well, it's too much work, we'll get a grant, so insurance should pay, but we'll get a grant. So, it's hard. The surgeons don't love this model either, but they're much better at it than we are at working the system, creating CPT codes, and then valuing it. So it's not exciting work, let me tell you, but I think it's important, and I think when I first came to Blue Cross, I was on a mission to get this covered, this service covered. So I was new, and I didn't really know everybody that I would need to talk to. So like, who does the coding? How do I get this covered? And it was automatically on the coverage list because it was a CPT code and it's sort of automatically ingested by the coding team. So then my mission became, oh, well then now how do we promote it? And it's like a whole different conversation. But a lot of other codes, they don't get automatically brought in. That system is sort of the core system and is just treated differently. So it was a learning experience on my side and coming to the health plan from the provider side.
Before you take the next question, another shout out that I have to give. I want to just shout out School in Carrington, who for our organization, the Massachusetts League of Community Health Centers, was the person who was charged with thinking about and leading our integrated care efforts. So School in Carrington, in the back, give her a round of applause, please. And I think School left us in 2024, but she's now Chief Clinical Officer at Wellness Clinic. She's the director there. So thank you and good to see you, School. Next question.
Good morning. Ooh, I am short. Shauna Shulman from the Richard and Susan Smith Family Foundation. I am so excited to be in this room having this great conversation. With apologies to the Undersecretary, we are all interested in creating a solution within this sector that also allows for prevention and health promotion and allows for billing of that. We've been very privileged to support an initiative that's working on that on the pediatric side, a fully integrated care model called Team Up for Children, which others in this room can speak more fully to. One of the roles, however, within that Team Up for Children fully integrated model, which Dr. Little pointed out, CoCM sometimes has a challenging, there are challenges to applying it fully to the pediatric population, particularly in the communities that Mike's folks serve. Is the importance of the community health worker role. And when we think about the CoCM model, I'm curious the degree to which those sorts of folks can sit in that behavioral health case management role, whether we can bill for their services in that role and the opportunities to do so within Massachusetts.
Everyone's jumping for this one. I think you, as other folks have mentioned, how we are defining collaborative care and what qualifies for the codes and for payment is evolving. And that's with more real world experience. Where it is set currently, each of the roles for collaborative care in order to build those codes, there's very specific criteria one has to meet and have them present. That creates the basis for it. You can always add more. That's going to challenge sustainability in that. And so I think for us in our system, we've certainly been challenged to see that. We're very lucky in that the role type that we have in the care manager is a highly skilled individual, and probably more so than in lots of other models. And that was something we intentionally chose for our practices and our model, because that's what our primary care network wanted. That's what our primary care physicians requested. And so that's what we've continued to build and support. And we know there are other needs. And so over the years, we've had to figure out how are we going to build in other resources to be able to do that and use some of the sustainability from the other parts of that operation in order to sustain that. So I think it continues to be an open discussion. We would love to see some expansion of who qualifies within the team that could then count towards kind of collaborative care time, collaborative care minutes, et cetera. This is the mundane part about billing. But I think that's where we need more experience. And I think as we continue to expand this model into special populations, so pediatrics, women's mental health, specialty clinics, we'll start to see where there are added needs, where the model itself and how we define those roles may be insufficient. And then to Greg's point, be able to then advocate where it counts in terms of defining and using these codes to better understand how we can then fund it and support it. But it is a continuous need that we're always looking to do, and we're trying to bring as much resources as we can to do it.
I would just add, I think one of the barriers that I see is that people, some practices are putting independently licensed social workers or somebody at that level in that care manager role, and that's not what it was designed. So the question is, could a community health worker, you have to meet all the elements, but it's a quote unquote staff role. It isn't an independently licensed person. So a community health worker, there's a certification for that, but it's not a person, it's not a role you would typically, somebody would put up a shingle. So I think it's what are they doing? I think there's more flexibility already built into the code than people imagine. So it's important to read the details and look at that. We have a practice that's come into our network that we were meeting that does OBGYN, perinatal care, and they call them a coach. They don't call them a care manager, but they are a care manager. They're just trained for that population. They're doing the full collaborative care model. So I think, we met with them. I was meeting with my network partners. They're like, well, we don't, coaches are one thing. I'm like, let's not get tripped up on the word. It's a staff person that's a care manager. They're doing that role. They've described the service with fidelity. They knew the ins and outs of it. We weren't going to get tripped up over that. And so, we're trying to promote those to our OBGYN practices who are doing screening, and they don't, I think they need more than the McPAP for moms. That's insufficient and doesn't have as many touches and all of that the collaborative care model does. So I think there's a lot more flexibility in that code because it's a staff role, not a professional role. The two professional roles are the PCP and the psychiatrist. The other thing is, somebody asked about like the psychiatrist being in the network earlier in the talk, and it's not relevant because the psychiatrist isn't typically billing. So if the mental health side, the collaborative care is a turnkey and is doing the billing, then they would need to be in network. But if you're hiring somebody, that psychiatrist isn't doing direct service. They're supporting the collaborative care role, and the primary care is billing it. So it solves for that problem, just by its nature if you're billing it in primary care. So.
And,
Okay, gotcha.
yeah, and I would also agree with that. I think, as you were saying, Dr. Harris, that the code allows for billing by a lot of different individuals, and I think it could include a CHW if they're doing the work. I think in my personal experience with hiring and sort of overseeing the care manager person, in the very beginning, it was very hard to find someone who had all the skills, but we really found, I think, if people had some sort of sensitivity, the ability to sort of talk to people, listen, respond to them, work, like sort of create interventions, we could teach them some of the other material, we could teach them some of that mental health material that they might not have come in knowing. And so I do think it's possible to train people, I think, if they just have some of these qualities. And we do see that CHWs have been moved into behavioral health roles in other areas. Dr. Margarita Alegria, who does a lot of health equity research, has actually been doing a project where she has CHWs delivering sort of kind of CBT-like interventions. So it's doable, just get someone who's kind of the right person to work in behavioral health, up-train them with skills. If they deliver the correct intervention, then they can meet criteria to be billed.
Yeah, and I don't know what you'd say from Mass Health. I know for us, obviously, we can review records. We want to make sure the service is being done, but we want the innovation. We want the service being done, representing Blue Cross Blue Shield of Mass. When we're not looking for it not to be done, we're actually trying to actively promote it. That's why I'm here. And so, you can always, if you're thinking about implementation, have people run things by us sometimes, like, do we have an issue with it? And I think if I heard the model like this model, we had no issue with what they were doing. It was clear that they were delivering this service. So, I don't know.
I do want to add that I think one of the more phenomenal organizations in this state is Healthcare for All. So I saw John McDonough earlier. I knew Rob Rastusha. And my cousin is here, Suzanne Curry. Folks will laugh if they knew Suzanne. We call each other cousin. So I just want to give them a shout out as well for the tremendous work that they do to represent patients and residents and communities. So thank you. Last question.
Hi, I'm Ian Lang from the Brookline Center for Community Mental Health, and less of a question and more of a statement. We actually run the collaborative care model for Wade Altman's practice, the family practice group. It's our staff that's doing that work. And so at the risk, sort of people asked earlier about, are there press in the room? I'm hoping there's no people who are paying claims in the rooms, because at the risk of coming into violation of that, we are using in pediatric practices community health worker types who've been trained to provide that care, and find it's a great extender to ensure that we can provide access, particularly given the workforce shortage that we're currently experiencing for independently licensed staff. So just more of a comment about your question. So just wanted to make that statement. Thank you.
I think that's one of the benefits of the coding structure. It helps with the workforce problem, and it aligns the psychiatrists to see more patients indirectly through the primary care practice.
Maybe since there are no more questions, just any closing comments. We'll start with you, Kiame. We'll go down the table. Something profound, please.
So let me start with something that's not profound. One of the things that I'm really hoping AI will do, one of the things that's really striking is how differently behavioral health specialists are trained from medical specialists in terms of even the documentation. And one thing that's always striking is that the way I write my notes is particularly not useful to a therapist or a licensed social worker. And so one of the things that I'm hoping is going to come out of it is an automatic system where when I open my note, the AI system will go troll the notes of the psychiatrist and the therapist and pick up the things that I would actually care about to know that happened in that encounter and import it directly into my notes so I can just read like one paragraph as opposed to hunting through notes. So that's like my non-profound thing. I would say that closing remarks is that we still have a system that to some degree, a culture that to some degree that stigmatizes mental illness. And so that's sort of a barrier to integration that we haven't really sort of brought fully in. It is one of the barriers that we experience when we try to integrate things. And I also think that our system, like the chassis system, the fee-for-service chassis system, again, I want to emphasize it, it's built on acute things happening. And so this idea of moving the system towards a chronic disease management or preventive management or wellness system, this is a struggle. It's a real struggle for us because all of our major stakeholders who have power are, including my own system, is built on preserving this system that's built on acuity as opposed to population health. So I just think that between those two things, between the stigma of mental illness and the fact that we don't have a prevention-based system, I think it is an uphill salmon jump for at least my career.
Yeah, well, it is swimming upriver, but there are people here who are like building fish ladders for us, right? So, I don't think I have a profound words here. Maybe it's more just sort of advice. Everyone here we're preaching to the converted here. I recognize that. And if I were to sort of share one thing for implementation, I did say that you have to think about the whole spectrum of care, like where are you going to send people? You need to have a plan for it. I also really firmly believe that collaborative care needs to be one of the first things that you work on, that you need to sort of get it in, because it is so different from what people are used to, that I think if you're going to try to promote acceptance of it, if you kind of put in all the elements first that people are used to, it's really hard to sort of introduce them to a new idea because people are going to go down the same sort of pathways. So if you are starting from a fresh slate, if you're trying to figure out how to do it, think about doing this early. So that would be my wish for everyone here.
Thank you, Dr. Chang.
again, nothing profound. I would leave everybody here with that. It really is, it's possible. I think the things that you think have been barriers to doing this or getting started are overcomable. There are community people here who want to help and see this happen in all our different communities. And I would just, really highlight the need for partnership. So wherever you are, wherever you want to implement, there's a partner. Find that partner, work together. If you're on the behavioral health side, find someone in primary care. If you're on the primary care side, find someone in behavioral health. There, as you said, there's lots of folks here who are among the converted. Find a partner. And with a shared voice, you all will be able to be successful. It definitely is possible.
Partnership, shared voice. Thank you, Doctor.
Oh, last, no pressure, as my piece would say. I want to share that. I think it's very doable. I really feel like if all practices had this integration model, again, this is this and other things, I think that would be transformational. If every practice had a primary care, if I could tell, I talk to accounts and employees at accounts all the time. It's Mental Health Month, and we have a wheel of traditional mental health and subspecialty mental health, and what do they get their EAP? And I have this primary care piece on the wheel. It's like, can you imagine getting your mental health services at your primary care? Most people really can't. And that, I think, would help with the stigma. So I think it's a foot in the door of really doing that. And it's based on that prevention, screening, and making sure that you're leaning into what's going on with somebody in the moment when they're in that primary care office, which is often when people are coming. They're not in the mental health office, they're in the primary care office. And if you screened everybody and you had something you could do if they were suicidal and you could assess them, you'd save a life. And I think it's doable, we can be optimistic, and I think that would transform things for people if that model is universal.
Thank you, Dr. Hayes. Give them a round of applause, please. Phenomenal panel.
No, wait. I think Michael needs to give us something profound.
Michael,
Not after getting up at 3:30 this morning.
You know what? There are two things that make these panels successful. One is to get the right people who have on-the-ground experience, both in policy and in practice, and in organizing and delivering these things. The second thing is to have a moderator that's dynamic and charismatic, but above all is curious. And so we really thank the panel, and thank you, Michael, for organizing this. Dr. Little, are you with us still? She needed to run. Outstanding. Donna, I want to thank you. Louise, I want to thank you. What a great collaboration to work with you. It was just such a pleasure. Phil Johnston's staff. Jane Lang did the communications for us, got out the press release, press advisory. Carrie Haig. Carrie, are you here? Thank you for all you've done for the forum for over all these years. You are outstanding. Ashley Osorio, everything you do for the Mass Health Policy Forum, we really appreciate it. People, we will keep in touch. I think Ashley will send you all the issue brief and send you all the PowerPoint slides, and we will let you know about upcoming forums. I want to thank my board. I want to thank the sponsors. Be well, everyone, and stay dry.